neurobehavioral consequences of stroke are important for patients because they cause enormous distress to patients and their families. And indeed, the burden of stroke that has been described, which include about 143 disability adjusted life years, part of that, a portion of that burden is because of these neurobehavioral consequences. They have a huge impact on patient outcomes after stroke in terms of mortality, disability, and even ability to participate in everyday activity that the inpatient could participate in before the stroke. Post-stroke depression is highly prevalent both globally and in sub-Saharan Africa. The consensus is that about 1 in 3 stroke survivors globally will develop a post-stroke depression. But the rates are slightly higher in sub-Saharan Africa, and there are studies that have quoted 41% compared to the 31% that is quoted in the global literature. And one reason for this higher rate in sub-Saharan Africa is because of the inefficient care available in the acute phase of stroke. So most patients in sub-Saharan Africa end up with more morbidities, including depression and other neuropsychiatric symptoms. So post-stroke anxiety is slightly less common than post-stroke depression. So the general consensus is that about 2 in every 5 stroke survivors will develop anxiety after stroke. Of course, people worry about whether they are going to recover, worry about whether they are going to lose their job after stroke. But most importantly, most patients with post-stroke anxiety also have comorbid post-stroke depression, and that increases the impact of post-stroke anxiety beyond the impact you would have seen in people with just anxiety without depression comorbidity. In sub-Saharan Africa, similar to depression, post-stroke anxiety is also very common. The figures are just slightly higher than the global figures. So we've had studies quoting around 25%, which is 1 in 4 stroke survivors in sub-Saharan Africa with post-stroke anxiety. Yes, relationship really would be in terms of both of them appearing together in most cases. So many patients with anxiety will also have depression as a comorbid condition. In the same way, many patients with depression, especially with the milder forms of depression, will also have anxiety as a comorbid condition. Another relationship between the two conditions is that both conditions actually respond quite well to treatment, both antidepressant treatment, medications, and also psychosocial interventions. In fact, they are one of the most responsive post-stroke complications to treatment. And indeed, another relationship is that these two conditions are highly prioritized by people who survive stroke and their families as issues that they will want resolved in the period after stroke. So as I said earlier, it's very, very important for neurologists, clinicians to know that these conditions are treatable. They respond very, very well to antidepressant treatment, whether pharmacological treatment or psychosocial intervention. So it is important for clinicians to be able to then identify these conditions so that patients can benefit from the treatment that is available for them. Currently, many patients, many stroke survivors with depression and anxiety are not identified at all because there are no screening tools, and then most clinicians are focused on the motor disability after stroke. As a result, even though these conditions are treated, many patients are unable to benefit from the treatment that is available.